part of the challenge for us is to get behind the words, be able to identify the primary objective, the point of what health and social care services are about, and the improvements that we need to make. This can be captured in a simple way by using a visual. So if I draw an axis here, and down the bottom we have a timeline that can be days, months, weeks, years. And then down here we have another measure. This can be a measure of need. And here is our happy and healthy zone. The place we want to be, we want our families, communities and friends to be, largely served by universal services, both formal and informal. Our libraries, our sports centres, our community-based resources. And then as we go up here, we get to higher levels of need. And this need is measured by whatever health and social care issue is around, including, and let's use for this purposes, healthcare. So at levels 9 and 10, we're talking about 24/7 care, constant comatose or vegetative states requiring 24/7 intervention. And then the various levels of need in between. On top of this, let's introduce a crisis line. Now, for these purposes, let's assume that that's entry into institutional care, and let's say that's acute hospital admission. Everything above this line represents institutional-based solutions. Everything below this line effectively represents community-based solutions. Everything up here represents high levels of need, high levels of human misery, and indeed high levels of public funding and taxpayer funding. So high cost and need. The further down we get, as I say, down to our happier and sort of healthier zone, we also see lower drains and costs for the taxpayer. When I go round and talk to staff, one of the first questions to ask is how, in everything that we do, both in terms of our business planning, but indeed our daily activity, no matter where we work within the health and social care system, how do what we do every day achieve this primary objective, bringing down levels of need as far as possible, bringing up independence and interdependence, community engagement. And what we can then do is overlay on top of this a typical need trajectory. So if we can use this in terms of children's health and social care and safeguarding and adult safeguarding. We can use social care trajectories and housing needs. But for this example, let's look at a typical case: older person living alone, falls and breaks her or his hip, and therefore a steep trajectory into an acute hospital admission. Sometimes staying there for too long, picking up other infections and conditions, and indeed not having a positive health experience, and also possibly leading straight from there into institutional-based care prematurely. What we can then do is think about, right, what needs to happen to avoid that experience. In the UK and in many other countries, as resources have got tighter, public services have shifted resources from this lower level need and just raised it up to meet these urgent, more urgent and acute based needs. We have things that we can overlay this, like eligibility for health and social care, and the various levels that we determine a state-funded service is provided at. And of course, the other tendency and risk is for public services to raise that eligibility threshold higher and higher and higher. Now, there's been plenty of research done over the last 10 years in the UK and elsewhere that shows the net effect of that policy is to move higher and higher levels of need, to withdraw from the prevention and simply raise levels of need, raise levels of human misery, and indeed raise levels of cost and public resources. So let's look at an alternative model to that. What can we do at this stage to start intervening earlier and indeed maintaining good health and well-being before it even starts to deteriorate? We know that there are some key indicating factors: social isolation, poor health choices, poor eating and drinking behaviours, smoking, drug and alcohol addiction, unhealthy relationships, abuse and neglect. There are a whole range of factors that we know drive up levels of need. In this case, for our older patient, poor environment that caused her to fall, or him to fall and break his or her hip. Again, these are things that can be avoided. So how do we put strategies together that enable us to intervene earlier? Not just using statutory social services, but how we can join the dots with a range of community services, the voluntary and third sector, other universal services and community-based support. The joining of the dots, the sum total greater than its parts argument, that if we join those dots, we create an intervention and experience that acts as a preventative influence over the escalation of care needs. So this outlines how we need to pull preventative strategies together that bring us together as a health and social care community with our partners and stakeholders to intervene earlier and avoid this escalation into care. Of course, for some patients, it's appropriate. We need to have a good quality and timely hospital-based interventions, and indeed nursing and residential home care. But we do so managing the process and the integrated pathways that make sure that if it's not needed, it isn't the default position. So we need something here that also acts, it's often known as your step up or step down services, your intermediate care or rehabilitation services, but something that can act to avoid an admission if it's not needed, because hospitals are not healthy places to be, and they should be avoided unless absolutely necessary. To see if care can be supported and care needs met in the community as close to people's homes as possible, with multidisciplinary joined up services at this point focused on rehabilitation, making sure that healthcare and social care needs are met, to try again to manage that trajectory, manage the entry into hospital care, focused intervention that then draws out managing trajectory A. Again, initially, if necessary, into an intermediate care or rehabilitation environment, to be able to fully assess in a multidisciplinary way our clients' needs and manage trajectory out as the priority. Back home in the community, constantly driving down needs, and the joining up here with universal services, with other sources of support that enable people to be active, to be positively mentally stimulated, that avoids some of the high risk factors that again would drive up need. Innovation and using techniques to also help with that agenda is a key challenge for us as well. But where further care is needed, where institutional-based care is required, it's informed fully by this multidisciplinary assessment, so that trajectory B is managed effectively, that needs are understood, and so the patient, the customer, is enabled to have the right environment and the right care at the right time. Thank you.